afternoon, everybody. I am looking forward to chatting to Dr. Simone today from the Zita West Clinic. So he'll be joining us very shortly. I'd like it if somebody could tell me whether I'm live. Oh, fantastic. I see that the clinic has joined, which is brilliant. So I'm looking forward to speaking to Dr. Simone. Loads and loads of questions we've had through, so I'll get through as many as we can. And he'll be on again, I'm sure, even if we don't get through. So I'm just waiting for him to join me now. Brilliant. Simone, how are you?
Hi, Zita. I'm very well. How are you?
I haven't seen you for a while. How have you been?
Yeah, very well, thank you. Busy, but fine.
I'm just trying to turn my sound up. That's better. Can you hear me?
Yeah, I can.
Yeah. So we've had lots and lots and lots of questions in. I'm going to try and get through as many as I can. And it's a real mix of questions from women trying naturally through to IVF. And I think it's important to say, just because we're an IVF clinic, it doesn't mean to say when somebody comes to see you that it will be IVF that they need. You know, sometimes you work with women for a lot longer, don't you? Because they're not quite ready for IVF. They want to try everything to tick those boxes before they go down the IVF route. So I think that's
very true, Zita. That's very true. I always tell patients IVF is always my last resort. So I always try to help patients achieving pregnancy in the most possible natural way. But clearly, sometimes IVF is the only option.
Yeah, and sometimes it takes them a while to. They need to have that time to try and make changes before they go down the route, don't they?
Yeah, that's very true. And whatever treatment that they are embarking on, they need to be physically and mentally ready. That's what we do a lot. Everything starts with a good preparation, whatever the route will be. And they are more likely to be successful if they are mentally and physically prepared.
Yeah, and you spend a lot of time with that first consultation, don't you? Sort of planning a framework and what they need to do and what, you know, plan A or plan B is, which I think a lot of women really value that as well.
Absolutely. It is fundamental that the patient comes out of the consultation with a plan.
Yes.
Whatever this plan is, the patient would need to have a plan to work on.
Yeah.
That plan might be keep on trying naturally for a certain amount of time, or preparing to IVF if IVF seems to be the best option, but the patient will need to be given a clear plan.
Yeah, no, absolutely. So I'm going to move on to questions because we've got a lot and I hope I'm not firing too many at you. So this question is, my first cycle, and I think it's important as well, Simone, that when, you know, like if you're with another clinic, we're not advising about what you should or shouldn't do. You know, you've got a doctor that you're under. So this lady said, I have a question for this evening. My first cycle on gonal F, 3 blastocysts, but 2 failures. Second cycle on menopause, 0 fertilization. What would you recommend next? My doctor suggesting again menopause, but very hesitant. Or the long protocol, but he's left us to choose. I'm 37 with possible sperm issues as well. I mean, it's a difficult one without knowing the whole history, isn't it?
That's very true, Zita. So I think this kind of patient would need to either have a review with the doctor they are having treatment with, and discuss and being guided by the doctor about what would be the best option moving forward, or if they're not happy or they want to have a second opinion. I've got a lot of patients who come to me just to ask a second opinion, but this needs to be run through a proper consultation. You can't give an advice in 5 minutes without knowing the whole picture.
Yeah, and again, like with protocols, the long and the short protocol, which one do we use more commonly, would you say?
Well, more commonly the short, although I do believe they are both valid protocols. And again, in order to advise one or the other, we should assess the full picture of the patient, because what we always say, there's no one protocol fitting all the patients.
Yeah,
Okay.
and I think you're right, and I think women are so knowledgeable now. They're on the internet, they read, they can see everything. But I think protocols need to be individualized, and IVF needs to be appropriate to you. So one protocol might not fit with another. And I think for some women, and you see it, they come in and they say, I want a short protocol, I want a light IVF, I want soft IVF, I want natural IVF, when really you've got to sort of work out what's going on and what is appropriate for you.
Absolutely.
Yeah.
What I normally do at the end of the consultation, once I have examined all the data, all the test results, then I discuss what could be the most appropriate protocol with the patient.
Yeah. Okay. What does it mean if you have a thick endometrium for an IVF cycle?
Well, it might be, if it's too thick, that might actually reduce the chances of an embryo implanting. So sometimes we have patients who, that is mostly the result of an excessive response to estrogens, which some patients tend to have. So when we see that, we normally suggest, if the thickness is really too much, to consider freezing the embryos and implanting them on a subsequent cycle, when we hope that the thickness will come back to normal.
So when this lady said thick, how thick? What thickness would she be
Well,
talking
normally
about?
we have a cutoff, which is around 13 millimeters at our clinic. When it starts being above that, then we are a bit worried that the implantation might be affected.
Okay. And so when women have the embryos put back on a frozen cycle, the endometrium lining will be better.
Normally it is, because they don't have the effect of the injections,
Yeah.
which is what makes the lining too thick in some patients. Yeah.
Okay.
So on a frozen cycle, they're not injecting themselves because they don't need to.
Yeah.
So the lining is very likely to be within the desired range, which is between 8 millimeters and 13.
Okay. You've just answered this question for this lady. What is the best thickness for a successful, I can't see what it says here, thickness for a lining for a successful pregnancy? My FET was just cancelled as my lining was 6.3 to 6.4, increasing the estrogen the next cycle.
That's what I'm saying. So the optimal level is between 8 and 13 on any cycle, fresh or frozen.
Yeah.
Sometimes you have patients falling out of this range in both senses. So they have below 8 or above 13.
Yeah.
And that's when the doctor needs to elaborate a specific strategy next time in order to bring these patients back to what they should be.
Okay. A question here. Do hot baths on a daily basis have a negative impact on trying to conceive? I was told to avoid baths after embryo implantation, so I'm now wondering whether I should avoid hot baths when trying naturally. In the meantime, as we only get one cycle of IVF, which was unsuccessful.
Yes, I mean, exposing the embryo to a high temperature is never a good thing. So my suggestion would be to avoid hot baths around the time of conception and a few days after an embryo transfer. Yeah, that's always a good thing to do, because clearly you don't want to expose an embryo to too high temperature.
Yeah, yeah. When would be the last scan to check the lining before an FET, e.g. day 10? I mean, we sort of like micromanage a lot of cycles, don't we? So there's always a conversation that is going on. I don't know how you would answer that one.
Well, I mean, we normally on standard cycles, we scan on day 12.
Yeah.
Okay. So anything between day 10 and day 12 is a good timing on a standard patient. It is different if we know the patient hasn't responded very well in a cycle. In this case, I like to see the patient earlier on the next cycle in order to be like day 7, day 8, in order to be able to intervene with some changes if I need to. But let's say on a standard cycle, anything between day 10 and day 12 is okay for a frozen cycle. On a fresh cycle is different. On a fresh cycle, we monitor much more frequently because we need to assess the development of the follicles. So on a fresh cycle, we do at least 3 scans every other day, from day 6 to day 10.
Okay. Another question which feeds into this FET one is, what are the tests you do for somebody having a frozen embryo transfer? Are there extra tests?
Well, I mean, again, it depends on the history of the patient. If it's a repeated failure case, then there are some tests that can help individuating whether there are some underlying issues. For example, now there is an interesting test which has been developed by the EV group in Spain, which is able to check for a few things. For example, what is the best timing for the transfer in that specific patient, and also to determine whether there is an infection and whether the microbiome, so the amount of lactobacillus, is appropriate. And now this is achievable with just one test, which will check all these things. So,
and how is that test done? Is it a swab? Is it?
No, it requires a biopsy of the uterus.
Yeah.
Okay. So it doesn't require anesthetics. We just give a painkiller half an hour before the procedure. It is a bit uncomfortable, but it's normally quite quick. It takes just a few seconds. We need to take some material from the uterus, and then this material is analyzed from the lab, and the lab will be able to assess all these things. That can be helpful, particularly in those cases of repeated failures for unexplained reasons. But then each case needs to be looked at singularly, basically.
Another lady's asked about ERA and ALICE, some of the extra tests that are done.
That's what I'm talking about.
Okay.
ERA and ALICE is the name of this test.
Okay. And are they done frequently, or you choose the clients that you use these tests on?
No, they're not for everyone. I normally choose carefully who is candidate to this test. Normally it's more for repeated failures without a valid explanation, or in women who transfer genetically tested embryos and still fail. In which case we know the embryo is genetically viable, so we look at other possible reasons for the failed implantation. Okay.
Would that be similar to having a biopsy taken when having an endometrial scratch?
Yeah, it's similar to that. It's very similar to that. Yes.
Are we still doing endometrial scratches, or
well,
not that much
we
now?
stopped doing it because there was a larger randomized controlled trial which didn't show any evidence. So and we are always guided by evidence. We try to be guided by science as much as possible, at least where the evidence is present.
So and it's a very I think it's a very painful procedure to have done as well, isn't it?
You are really absolutely right. So after the study came up showing no difference, then we have stopped doing it, because I mean, to be fair, we have never done many of these, but now we have stopped pretty much completely because because there is no evidence it might actually make a difference.
Somebody's asked here about sperm DNA fragmentation as well, for male fertility, and we do a lot of those tests, don't we, in terms of male fertility?
Yes, I mean, the DNA fragmentation is is a helpful test, because actually the standard semen analysis might not pick up some conditions like DNA fragmentation. So that's particularly helpful, particularly in those cases of unexplained infertility, when the semen analysis looks fine at the first look. And then when you run the DNA fragmentation, you find out eventually that there is a problem.
Yeah.
So again,
but it's interesting. Even though a man's sperm might have good results, it doesn't mean to say that there's not DNA damage. And I think for some clients, it saves them time, because it would be going straight to ICSI as opposed to doing a couple of rounds of IVF and maybe it not working.
Exactly.
Yeah.
That's very true. That's very true. Actually, if the DNA fragmentation is very high, there seems to be evidence that the ICSI is the best way forward, even if the semen analysis looks fine.
Yeah. And there's another thing that we're using at the clinic now. Is it Zymot, where we're able to sort of check the sperm? And how is that going?
Yeah, I mean, it's very promising, although, I mean, first of all, it's not a new technique. Is in some clinics, particularly in the US, is a very established method. Okay,
Yeah.
we have just started more recently to use it, but actually the science behind that looks quite strong, and it seems to select better the sperm with the less DNA fragmentation. So it's particularly helpful for ICSI, okay? And it seems to select better the sperm as compared to the standard way.
Yeah, yeah. Even the sort of greater magnification, IMSI.
Yeah, that would be interesting. To my knowledge, there haven't been studies comparing the two. So it would be interesting to see a study comparing what has the better outcome. But my gut feeling is that the Zymot could replace in a lot of cases the need of IMSI.
Yeah, and it's quite a cheap thing to do as well, isn't it? It's not expensive.
Because the difference is that with IMSI you are still leaving the choice to a human, so to the person assessing the sperm, okay? Just based on the morphology. Whereas the Zymot works in a completely different way. So we would expect more accuracy in selecting the best sperm. Because it's a more automatic process. So the risk of human error is reduced.
Yeah, no, absolutely. So there's a lady here. When will steroids be returning? Because obviously with COVID, we haven't been using them. I've had 8 failed cycles. I've had 8 failed cycles. The last cycle ended in obviously she got pregnant, but miscarried at 7 weeks. Any help welcome. Have got 4 embryos left.
Well, we have actually reintroduced the steroids now. So a few weeks ago. So so this is now given again. Only those patients who might benefit from it. We don't give any treatment empirically. We normally run some tests.
And with this lady that's had failed cycles and early pregnancy loss as well, there may be other underlying factors. It's not just about steroid, is it? There's other things that need to be
exactly. I think
this
patient would be a good candidate to have some test done to look into a possible reason for these recurrent miscarriages. And then if a problem is then identified, then there is a treatment that can be successful to increase the chances for patients with recurrent miscarriages to achieve a successful pregnancy.
Yeah. Somebody's asking here, should I continue to take Zeta West CoQ10 after transfer? It won't do any harm at all. CoQ10, ubiquinol, is very good for the mitochondria and for energy. So taking it after transfer will be absolutely fine. What's got it here? So what is your usual dose of Ganassi for trigger injections? I was told to take 5,000, which resulted in poor yield at egg collection. and a second opinion suggested this dose was too low?
Well, you know, it's always easy to speak in insight, you know, when,
Yes. Yeah.
yeah, we are all professor in insight. But generally speaking, I think when there's no risk of hyperstimulation, 10,000 is the standard dosage we give.
Yeah.
We give 5,000 only when there is an predicted risk of hyperstimulation, or sometimes we don't give gonasi at all in case there is a high risk of hyperstimulation. We only give a different drug called buserelin.
Yeah, yeah. So when, you know, like every part, isn't it, Simone, every part of an IVF cycle is important. And where we're sort of different is that we do prepare women. We look at nutrition, we look at acupuncture, counselling, hypno. But then as they're going through a cycle, they have regular scans, blood tests. And I know there's a couple of markers that you look at, especially around progesterone, don't you, in a cycle?
Yes. Yeah, progesterone is one of the things that is associated with outcome. And it's important to differentiate the progesterone during stimulation and after the transfer, because the cutoffs are different. So during the stimulation, the progesterone doesn't need to be too high, because if it's too high, then this predicts not a good outcome. So if it's too high during the stimulation, we prefer to freeze the embryos and transfer them on a subsequent cycle once the progesterone has come down. Whereas if the progesterone is too low after the transfer, that's the opposite. We need to increase the level of progesterone, because the progesterone needs to be high around the time of the transfer and after that. So in some patients, we check progesterone before and after, just to see if he's in the right range. So yeah, I agree with you, Zita. The treatment would need to be as much personalized as possible, and that's why the preparation and discussing each case in advance dictates what will be the choice of the treatment and the level of monitoring a patient would need. These are all things that can't be standard.
No,
they really need to be personalized, and that's what we try to do at our clinic as much as possible.
Yeah. So would you recommend progesterone pessaries for recurrent miscarriage? And if so, at what stage of my cycle pregnancy would you recommend it?
Well, first of all, from the question is not clear whether it's on a natural pregnancy or on an IVF treatment. I take it is on a natural pregnancy. I mean, it doesn't do any harm to take progesterone on a natural pregnancy, particularly in those cases with recurrent miscarriage. There is no evidence either it might particularly help. But in my personal opinion, it doesn't do any harm. So the best time to take it would be actually 3 days after ovulation, and in case of positive test, to be continued until 12 weeks.
But you need, I mean, the thing is, you can't just go off and take it. You need to be with a specialist to do this.
It takes a prescription, so you can't self-prescribe.
Yeah, and also being monitored, and you know, having a cycle monitoring and sort of working out exactly what is going on, because there are so many things why miscarriage can occur, underlying factors as well. Somebody's asked here, what level do you look for the progesterone on embryo transfer day?
That's a good question. It very much depends if it's a frozen cycle or a fresh cycle. On frozen cycles, actually the cutoff, although it's still debated, but a good cutoff would seem to be around at least 30. On a frozen cycle is a bit higher. It seems to be around 50. Okay, but it's still controversial. So basically, there's no agreement on what is the ultimate cutoff. Every clinic, each clinic has their own cutoff. I told you what is our cutoff, but I know other clinics think differently. So,
but it is, you know, like you see that we get better results as for testing.
Yeah, we try to keep. Yes, there's no doubt, there's no question about that. If the progesterone is too low, this is associated with increased risk of miscarriage. That's why we try to keep it above 50 as a general rule.
Yeah. Okay. Another question here. I started preparation for a cycle for IVF, but my TSH level is elevated to 5.94. My GP thinks that obviously I've got thyroid issues. Prior to the beginning of the cycle, the TSH was 2.9 and 2.25. This was deemed acceptable by my clinic. What causes fluctuations? And my clinic won't start a cycle again until I've had 2 TSH readings within acceptable range.
Yeah, well, thyroid function is one of the things that might affect the outcome of IVF. So again, it is now established that a good range would be between 0.5 and 2.5. Everything outside this would need to be looked at. So I agree with the indication that was given to this patient. If she moved from 2 to 5, that probably is the sign that something is happening. So the thyroid would need to be brought back to a good balance. Normally, the easiest thing to do in this situation is to give the patient thyroxine, which is the hormone produced by the thyroid. And most of the cases can be resolved by giving the right amount of thyroxine to bring the levels back to what they should be.
Yeah, I'm always amazed though, Simone, and maybe because we're testing more, we know, but the amount of young women that have thyroid issues now seems to be really high.
Yeah, that's true. That's why one of the basic tests that we recommend before starting anything is the thyroid function and vitamin D. These are the two things I find mostly either too low. The vitamin D is very often very low, and this is linked to the fact that we don't have too much sunlight, so we don't absorb vitamin D as we should. And for the thyroid, you are right. A lot of women, even young women, do have the thyroid not working properly. That's why we run these 2 tests as a really basic test for all the patients.
Yeah. Okay. One here. I have endometriosis. I would like to try other options before IVF. How successful is IUI and Clomid?
Well, you know, there is no link with endometriosis. So endometriosis, unless is very severe, which is a different matter, but if it's mild, shouldn't affect too much the chances for a patient to get pregnant. Clearly, if the pregnancy doesn't happen within 12 months, probably I would think about IVF, because IUI and Clomid in a patient who has been trying for more than 12 months are not changing the success rate significantly.
Yeah, and there may be sort of procedures that she will be having, you know, like operations to sort of remove the endometriosis. But again, just on this, we don't know what stage of endometriosis
Exactly.
it is.
The
Yeah,
stage is very important, Zita,
yeah,
because
yeah,
mild stages do not affect fertility too much, whereas when the endometriosis becomes severe,
yeah.
normally IVF is the best line of treatment.
Yeah, and I think as well, it's like we were saying earlier, it's good to be able to try things beforehand. And, you know, again, if you've got endometriosis, it's likely you've got inflammation in the body. So there is diet, there's supplements we can look at. We can look at vitamin D. But I think the age factor is really important in somebody. And so it's fine for them to tick the boxes and try something for 3 or 4 months. But if it's not working at that point and they're in their late 30s, you've got to look at what's going to give you more success. And that's probably something like IVF.
Absolutely, I agree.
Yeah, yeah. Okay, I'm due to start my IVF hopefully in June. My AMH is 12.5. My consultant doesn't feel this is too low. I'm 29. What do you think? Well, I think that is, you know, she's 29, so young, isn't she?
Yes, I think a patient at that age shouldn't be too worried about the AMH because the prognosis is very good.
Yeah.
So a patient at that age shouldn't be too worried about the AMH. By the way, 12 is not a bad.
No, it's not. It's not at all. And the younger you are, the better it is. So
I wouldn't be too concerned. But still having the right counseling from a fertility specialist is important. So rather than looking at just one thing, is the full picture of the patient that will guide the choice of what to do.
Yeah, I mean, the sad thing would be this lady at 29 probably doesn't even need IVF, so she'd be better off doing other stuff first and work within the timeline.
First of all, I always say it's not a woman problem, it's a couple problem. So I would be interested to see the other part, so the other half. So for example, a semen analysis from the partner of this patient to see whether everything is fine. We don't have to think that the problem is always on the woman's side.
No, absolutely. Men are 50% responsible.
Exactly. So you can't just take the woman and treat and think that the problem is coming from the woman's side. Yeah. We need the full picture.
Yeah, no, absolutely. A lady asking here, is there anything that can be done to improve embryo quality? Would love your view on PGTA testing.
Well, I mean, again, PGTA is not the holy grail. It has some indications, but it also has some potential contraindication. So it's always a discussion with the patient as to whether in their specific case, genetic screening can be more helpful or can do more damage. Okay? Yeah. Again, no one size fitting all, no genetic screening for everyone. Because, for example, if a patient will produce only one embryo, then in most of the cases, much better to transfer this embryo back and give this embryo the best of the chances. Okay.
Yeah.
Rather than considering the genetic screening. And ultimately, the genetic screening doesn't offer any insight on the quality of the embryo, but will just tell us whether an embryo is genetically viable or not. So it's not a measure of the quality of an embryo. It's a completely different thing.
Yeah, and also it's quite useful, isn't it, in older women if they sort of batch their embryos and have them tested.
Sorry, say it again.
It's better in older women, isn't it? If possible.
Absolutely.
Yeah, yeah.
It's better in older women because older women have higher chances to have a genetically abnormal embryo.
Yeah.
So they will have most of the benefit in having their embryos tested, because we are expecting a higher incidence of finding a problem.
Yeah.
So
Okay.
yes,
Yeah.
it's more indicated in older women. That's correct.
Yeah, I'm going to end on this question, which is a very sad question. My son passed away at 37 days old in December last year, which must have been horrendous in the middle of COVID. No one predicted he would pass away during my pregnancy or when he was born. We've done extensive genetic testing, including a WES test. No condition has been diagnosed, and we've been told our chances of a second child having the same fate are 1 in 100,000. Is there any medical procedure available to guarantee 100% healthy sibling? I mean, so sad for this couple.
Yeah, it's very sad. It's very sad. I feel very sorry for this patient. So the answer to the question is that unfortunately there's no test which is able to guarantee a healthy child, because even the genetic testing
Yeah. Okay. You're cutting out a little bit, but we yeah. Okay, we're cutting out a little bit, Simone, but we've come to the end of our questions. So thank you so much for coming on, and I'd love you to come back on again. No, I think I've lost Simone, but we've had a good session. I hope that you all got something from this. He doesn't realise this. So thank you, Simone, for coming on this evening. And next week, Dr. George is going to be on. So please send your questions through. If any of you would like an appointment with Simone, he's on 0808 196 4060. So just check in with the clinic to make an appointment. And I'm sorry he's frozen at the end, but we had a good session. No, he's still speaking. Okay, thank you everybody who joined this evening, and I will see you next week with George. Okay, thank you.